So the numbers are starting to flow in, and we are recording. So welcome everyone. We're just going to wait till the numbers pick up a little bit. Eager beavers, it's not even 7, so thank you for giving up your evening tonight. I think we've got the whole country covered. Kate, you're Dunedin. Sally's as far north as Auckland.
Yeah, under the dome of Auckland.
The cone, yeah.
Cone of Auckland.
Thank you.
Sammy's
Wellington.
Yeah. And Andy, you're Wellington unpicking. Yep. And I'm in the hot spot between Cambridge and Hamilton. Yeah. All right, so we're just waiting a couple more minutes. Just ticked over to 7, so maybe give it another minute or so. Get the last few people a chance to come on.
Good idea.
All right, so we might just start the introductions and then we'll kick off in a couple of minutes with the presentation. So tēnā koutou, my name is Olivia Haslam. I work for IMAC on the COVID-19 team as a regional immunisation advisor for the Midlands region. I want to welcome you all here who are joining us tonight and for those of you who are watching this later. We wanted to bring together a webinar as an opportunity to learn from pharmacies that are already up and running, both as an opportunity to learn from each other, find out what's worked well, what's been challenges, how we've overcome them, and just basically pull all our knowledge together. We wanted to touch on tonight as a reminder of what best practice looks like with COVID vaccinations, and also do a quick clinical update, which will be relevant to all pharmacists vaccinating or not. Few housekeeping points. We will save question and answer time until after the presentations. There is a Q&A button below on the Zoom to type in your questions at any stage, and we will do our very best to cover these off. This webinar is being recorded and will be available on our COVID website in the next few days. We are very appreciative to have the support of Andy Strickliff joining us tonight. She is the clinical chief advisor at the Ministry of Health, seconded part-time across to the COVID vaccination team. She will be here to assist with the Q&As at the end, so feel free if you've got something directed for her and her expertise at the ministry, she'll try her best to answer. Our speakers tonight include Kate Marshall from IMAC, and she is a Dunedin-based COVID immunisation education facilitator with a background in public health and nursing. Sally Schnauer is a pharmacist and is working as an education facilitator for IMAC, supporting the rollout of the COVID vaccine based in Auckland. We have the pleasure of Sammy Luang joining us. He's a pharmacy manager at Life Pharmacy, Manor Street, Wellington, to tell us what it's like at the coalface. I'll present last, but my background is as a community pharmacist and pharmacist vaccinator. So our numbers have stabilised a bit, so we might crack on. So Kate, take it away.
Thanks, Olivia. All right, bear with me, everybody, while I just make sure I get my screen sorted. Okie dokie, all good? Lovely. All right, so again, thank you very much, everybody, for coming along tonight, taking time out to attend. Now, we'll just start with a karakia. Tū taua mai I runga, tū taua mai I raro, tū taua mai I roto, tū taua mai I waho, kia tau a tai Māori tū, te Māori ora ki te katoa. Haumie, hui, tai kia. Thank you. All right, so tonight we've got a lot to touch on. Now, as Olivia described, I'm going to start discussing some of the basic onboarding and training requirements involved in setting up a COVID clinic. And then Sally will be discussing what IMAC clinical support visits look like and what best practice for your vaccine preparation and administration are. Then Sammy's kindly going to describe how his clinic rolls in Wellington, and Olivia will finish off by describing a few different models and case studies in the community, how they're running. Now this infographic here is a little overwhelming to look at, but it is a general overview of the onboarding journey that some of you no doubt have already navigated. For those that haven't, take a deep breath. It's okay. With a bit of planning and talking to your DHB, you can get through it and it's fine. Now on the far left-hand side, you'll see some priority actions which are really important to get started with for your first steps. And that includes talking with your DHB to get a formal agreement set up for your contract, and also getting your staff trained up nice and early. Then the process moves on to getting your site IT set up, your clinical considerations, your general workforce onboarding, and then finally site rollout and your operations. Now, in terms of a time frame to work to, it depends how your DHB does their contracting, but allow at least 2 to 3 weeks from start to finish to get your staff trained up and to allow some time for everything to get in place so you can start your clinics. Now, there's lots of tools and reference guides to help get your team started, and it can be quite a challenge to decide where to look first. But look, some of the things you need you already are familiar with, such as the immunisation handbook and your cold chain standards. Now, the 2 key documents that the Ministry of Health have created to look at are the Primary Care Onboarding Guide. Now, this is a how-to manual on setting up. It's really good. And the COVID-19 Vaccination Operating Guidelines. So we're up to version 24 of this now. It's very comprehensive, very fine detail, but it's a good nighttime read. Now it does update quite frequently, so I recommend you have it as a favourite on your computer at work. Now, for clinical guidance and best practice, make sure that all your vaccinators and staff are familiar with the IMAC COVID website. You can see the address there on the page. So this gives up-to-date clinical advice and resources, including webinars on all sorts of different topics that you can go and watch at your own leisure. Now, some of the documents that I'm referring to tonight, we can send out a quick links document to attendees, so you can access that when you like. Now, to get started with your clinic, some early planning will help ensure you have a really safe and successful COVID clinic, and that it suits your practice and your community. So the first step is to talk to your DHB, of course, and now there are regional differences up and down the country, how well supported DHBs are, and how kind of active they are with doing wet runs for you and engaging. So just touch base and make sure you know where you stand, and don't be afraid to ask for assistance if you need it. The next thing to think about is how to incorporate equity planning early on. So this is all about how you can design and promote your clinic to boost access to all members of the community. So how are you going to create an atmosphere of celebration so that people feel really happy and proud once they've had the vaccine at your pharmacy and want to recommend it to their friends and family? The next key tip is to get your staff started with all the free IMAC training as soon as possible. So the earlier you start, the more organised you'll be. And also to get your staff who are going to be using the CIR, so the COVID Immunisation Register, they need to have their own business email address. So this is necessary for security purposes. Now, once you're in the process of actually contracting with the DHB, you have to navigate the paperwork. It's not too onerous. Now, there's a CIR user form and an NBS, National Booking System user form, which need to go back to the ministry to get your staff set up. So make sure you've identified who's going to be using these programs. Next, there's a site checklist. So this is found at the back of the COVID-19 vaccine guidelines. The DHBs will use this as a checklist to sign your site off to make sure that you're all okay. Then there'll be a resource ordering form. So this is your initial kind of order of all of your resources, such as the vaccine cards, the information pamphlets, maybe the banner flag for the front doorstep, and also the paper-based consent form. So even though we do consent for this vaccine verbally using the CIR, it's good to have the paper-based consent just in case your IT crashes, or as an extra layer of protection if you want to consent somebody you feel might be a bit higher risk. Finally, the actual form that's used to set you up in this whole system is this one, the new facility site setup form, which goes to the ministry, and they use it and the information on it to put you, get your pharmacy in the system as a live site. Now, the main groan zone for onboarding is getting your staff onto the CIR. Now, it can be a bit daunting, but once staff have got on it, it's quite intuitive, it's reasonably hard to break, and it's quite easy to use. Now, the form goes to the DHB from you, and then that gets sent to the Ministry of Health, who will send your staff classroom links, and that's like the practice website for them when they're doing their training. The staff then complete their training on the IMAC website through the learning platform, and when they've completed the training, the DHB notify the ministry, and then your staff get their live CIR access. And that comes as a password reset email with a link that expires after 24 hours. So if your staff aren't keeping their eye out for it, it can be a bit frustrating. However, they can always call up the helpline to get things back on track. Now, they need to download a Salesforce app on their mobile to get into the live CIR site. And they use this every time you log into CIR. It's kind of like getting into your online banking. Here is the phone number for that ministry CIR helpline. They're really fantastic, very patient, so don't feel embarrassed if you're struggling to get your log on sorted. And the ministry also run daily drop-in sessions in the mornings to give a demonstration of how CIR works and also how Book My Vaccine works. And they're really friendly and you can ask them all sorts of silly questions. So it's really, really important that all your staff have got these their access sorted out before you have a wet run clinic or your first actual clinic, because it's a nightmare if you haven't got it sorted. And just log in every couple of weeks to keep your account live and active. Now, the contracts and funding for the COVID vaccine. So it's paid as a price per dose basis, and these prices here you can see they differ for when it's in hours and out of hours times, and all of the costs associated with the consumables and also training and everything like that of your staff has kind of been factored into this pricing, and yeah. So out of hours for the funding is defined as 8 o'clock at night till 8 o'clock in the morning, Mondays to Thursdays, and then after 5 o'clock on Friday till 8 o'clock on Monday morning, or any public holidays. Now, when it comes to actually staffing your clinic, it's really important that you involve all your pharmacy vaccinators straight off the bat. This is because they need to be across all aspects of this vaccine and its particular cold chain requirements. Now, you need to identify who's doing what in your clinic. So the number of staff you need will really depend on the volume of the doses that you're planning to deliver each hour. So for very small numbers, let's say you're just planning on doing 6 doses an hour, which would be 1 vial, you need at least 2 suitably trained people to prepare the vaccine, a vaccinator, and a person to do the admin roles of arriving people into the clinic on CIR and observing them. So if you're doing larger numbers than say 6 doses an hour, I recommend that you use a couple of vaccinators and have 2 different admin team members doing the arrivals and the observation roles. So it can be really busy. So don't expect that they'll have time to do the usual sales and customer facing work. In particular, the person doing the observation role has to be really focused on their job and watching the people after their vaccinations. Now, it is handy to have multiple staff trained up in your pharmacy on how to do different roles and how to use CIR, just in case you have somebody that calls in sick. Now, IMAC is the contracted education and training provider for the COVID-19 vaccination rollout, and this table shows the key courses that IMAC have developed for your team to deliver this vaccine. Now you can see the vaccinators there. Authorised vaccinators need to have completed the COVID-19 education course to prepare and give the vaccine. And this course also includes CIR and Book My Vaccine training. Moving along to the administrators. So this is your non-clinical staff. There's a CIR and Book My Vaccine training there. And there's also an optional immunisation support worker training module. This is really handy because it helps them have those kind of navigate those tricky immunisation conversations that people sometimes come up to them with. And it also provides some good grounding in what to do in that observation role. Now we've got some hot news off the press. So last week, IMAC released new training for pharmacy technicians. So this teaches them how to prepare the vaccine. It is a trickier vaccine. It's a multi-dose vial, and it can be a bit fiddly. So it's really helpful to have lots of staff trained up in how to prepare it at your pharmacy. It's people that can do it need to be qualified pharmacy techs or have at least 6 months training under their belt, but it's also suitable for non-vaccinating nurses and pharmacists who want to learn how to prepare the vaccine as well. There's also managing inventory, in the CIR. That's a training module that your pharmacy manager might want to do, and there's also optional training around consent for people with disabilities. Now, a new pathway for non-regulated healthcare workers who are interested in vaccinating is the newly created COVID vaccinator working under supervision role. So we call this CVUS for short. So if I refer to it, that's what I mean. They can administer the vaccine, but they cannot prepare it and they cannot do the health screening to gain informed consent at the start. So this needs to still be done by an authorised vaccinator in your pharmacy first. They also need to have a dedicated supervisor who's an authorised vaccinator who can assist them when needed and be immediately available to troubleshoot and provide guidance and support to them. So there's a training pathway for the CVUS workers, as you can see outlined there. Once they've satisfied all of those criteria, then they apply to the Ministry of Health for their authorisation. It may be a good thing for you to consider for your pharmacy technicians to do who want to administer the vaccine, and it might come in handy for them and for your workforce as a future-proofing aspect, and it provides a formal qualification for staff that do this program. Now, just to summarise again who can prepare Pfizer doses, authorised vaccinators who have done the COVID training course and pharmacy techs who have completed the pharmacy tech course can prepare doses. It's important to note that the only people in a pharmacy who can actually give the vaccine are authorised vaccinators, so either provisional or fully authorised, or CVUS workers under supervision. Now, before I hand over to Sally, I'd just like to share with you a graph from the Southern DHB. So this demonstrates how on a single day in August, in level 4 lockdown, close to 9,500 vaccinations were given district-wide. So each little individual colour of the rainbow there represents a different provider. So it just shows no matter how small the contribution from each different player, and this is pharmacies and GPs and all sorts mixed up, it really does contribute to getting the job done. So please do feel encouraged to hop on board if you haven't already, because we really want to try to get that 90% done for our country. All right, thank you. I'll hand over to you, Sally.
Thanks, Kate. That looks good. Thank you for that. Good evening, everybody. I've been fortunate in Auckland to have the opportunity to visit about 35 pharmacies setting up in the COVID space and offer support. Now, this support is usually, a visit is usually about an hour and a half and kind of covers, you know, woe to go from when a patient first walks into your door until they leave at the other end having been vaccinated. So we go through the whole process, look particularly at some of those tricky bits. It can also be done over Zoom. So if you're not nearby or, you know, to someone who can visit, very willing to do this over Zoom as well. Thanks, Kate. If we can go to the next slide. Thank you. I think it's quite interesting to know just the impact that pharmacy is making with this COVID vaccination. You can see there in green that there's about 1,100 pharmacies in New Zealand across the country, and around 800 of them offer what we might call our business as usual vaccinations. Of those, 309 have been approved and authorised to go ahead and deliver COVID vaccinations. And so we're really making a big difference out there. In fact, those 309 pharmacies have actually contributed to delivering 16% of all vaccinations in New Zealand, which I think is a pretty remarkable job for 309 sites. So there's opportunity for us to do more. To the best of our knowledge at this stage, we will start looking at primary care to be delivering this vaccination in 2022. Some of those larger, bigger sites won't be necessarily in the mix. So it will be primary care, and that's GP clinics, pharmacy clinics, and certainly at this stage looking at the possibility of booster shots for firstly perhaps the immune compromised, then the elderly and frontline health workers. So heaps of opportunities still out there, even though in some places it might feel quiet from time to times. Okay, Kate, thank you. All right, so getting started, just some tips really, hopefully to help you with your layout, you know, how you're going to consider that. It's a huge difference, isn't there, between big pharmacies, little pharmacies, and pharmacies in general compared with these super vaccination clinics. They all have their place. But it's about using the guidelines, which Kate said, you know, are really thorough and very good, and adapting them to your site. And that is possible, very possible, to do the right thing in different ways. One of the things that I think is important to think about is, you know, can you pivot quickly with a change in alert levels? I think we've all experienced that very recently, and certainly here in Auckland. Can you also pivot when demand is high and then drops off again? So think about your layout, think about what you can do with those spaces when those things change. Sometimes pharmacies, you know, it's a little tricky that the COVID guidelines for operating vaccinations in different alert levels are quite different than those that are coming just for general pharmacy business as usual. And that's sometimes a little bit hard to reconcile. But, you know, screening at the entrance, those requirements, as I said, can change. But can you screen a person at your entrance and also enter them into the CIR, you know, entering their details in what we call reception? Where are your computers already in your pharmacy? Can you use an existing computer, or do you need to think about getting, you know, laptops? How can you make your space work for what you're required to do? Your waiting area and your observation area. How can you sort of, you know, make that those two areas sort of together but also separate? Is it going to be coloured chairs? Do you label the chairs observation? You know, are they facing a different way so that it's really obvious as to who's waiting and who has already had their vaccination? Some of those chairs, it's a really good idea for them to have arms on them. You know, thinking about someone who's a little bit frail, elderly, even overweight people need a bit of assistance getting up off the chair. Wipeable surfaces at the moment in Auckland is a huge thing. You know, we need to be able to wipe in between those high touch points. So all those things are things that you need to consider, but it'll look different in any pharmacy. Okay, so preparation area and equipment. All right, the most important thing for this area is free of distraction and interrupted. Anybody who's been working in this space will tell you that it seems like it's fairly straightforward, but the minute that they are distracted, they're back in there going, where am I up to? So really important to try and have that distraction free. Super tough for pharmacies where we are multitasking all day long. The phone's ringing, somebody's waiting for a script, it needs checking, all these things. But you might think about drawing up your doses in the morning before the pharmacy opens and having those ready, knowing that they've got a 6-hour expiry, different things like that. Have you got a really good space? There's a lot of stuff that you need, 2 different types of syringes, 2 different types of needles, alcohol wipes, hand sanitizer, different labeling, saline. There's a lot of stuff. So think about, is your space enough for all of that? We need to follow infection guidelines as well. So just on that, making sure that when you do get things ready, you're not sort of opening packages at different times. That's super important. And I'll just mention hand sanitizer. The nurses that I work with are brilliant with hand sanitizer. They're very clinical and they use it all the time. They nearly bathe in it. Pharmacists, I've noticed, we're not quite as good at remembering, but it's a very important step. This is, you know, aseptic, so, you know, super important in that regard. The ministry supplies most of your consumables, your needles, your syringes, but you will need to provide some stuff of your own, things like kidney dishes or a hard-walled container, you know, different items. Maybe they've suggested using incontinence sheets, hand gel, sharp spins. They are all the pharmacy's responsibility. You'll notice down there, there's a wee picture just of those needles. I thought I would mention too. You've probably heard of these LDS needles, low dead space. And hopefully you can see the picture down there on the bottom right-hand corner that shows the difference between the 2 needles. One, the low dead space, which has got the needle coming through the hub, that's used for drawing up the doses. The other needle that perhaps looks like it's got a flat top, that one there is used for diluting. So they look really similar in their packaging. You will soon get very used to which one is for which. One screws in and one pushes in. And when you push it in, you need to give it a really good go. Otherwise, it's very easily able to be separated from the syringe. So cool, thanks. You can switch slides. Documentation, our favorite thing. There's a lot of it. There's a lot of it that you receive, and there's quite a bit of it that you need to fill in. So I thought it was worth noting that really we need to try and think of this documentation, this dilution record, as you know, as an example of how we have our other compounding records in pharmacy. When we do a compound, we're making a record of this, and this is no different, except that it's got a lot of steps. And it also is aseptic. So it's a process that we're really trying very hard to manage that infection control. Okay. These records you need to fill out, and they are kept for 3 years, just like any other compounding record. So I thought we might just sort of try and work through that there if we can. So vial number. We're asking you to record the number of your vial at the bottom in permanent marker underneath the vial. This is just to keep track and thinking of it as following the journey of that vial right through until those 6 or 7 syringes have been administered into a patient. It's going to help us just keep track in case there was something that went wrong, an error, we can narrow it down. You need to record the time you remove the vaccine from the fridge, as this starts that 2-hour expiry before you must dilute that vial. It does only take about 15 or 20 minutes to come to room temperature, but you do have 2 hours. And just a wee note there that if for some reason you had to put that vial back into the fridge after, say, an hour, you can do that. But you need to note that when you bring it out for the second time, you only have 1 hour left. So that 2-hour time is cumulative, okay? Also noting there that you need to record the batch and number for the saline and the vaccine, as well as the expiry for the saline and the vaccine. With the vaccine, I don't know, hopefully you can see this. I know that looks terrible with all that scribble, but that's ultimately what we need to do. You are getting the batch number and the expiry date from that lower label, which is the one that HCL uses when they take that vaccine out of their deep freezers. So that's just a handy thing to know, because that is what CIR wants you to record as you vaccinate someone. So record the time that you dilute the vial, and now there is a 6-hour expiry. That 2 hours is finished and done with. We're done with that. 6 hours. So we need to have a record of that and know when our syringes are going to expire. That 1.8 mils of saline that you use to dilute the vial with, you do need a second checker at that point. It's super important. We want to make sure that that's one of our checkpoints that's really important. Okay. Discard any unused saline at that point. We want to use that saline freshly. Okay. Try and get familiar. If you're new to this, I think it's really good to be able to get hold of some needles and syringes and play with them. Practice putting them together. Draw up some saline. Just get comfortable using needles and syringes. That would actually get you a few steps ahead before you're actually using the real thing. Go and watch. If you've got a friend who's got a pharmacy who's set up, go and watch them. Go to a big centre if you can get in there. Take advantage of any coaching that we can do, and we certainly take equipment with us and leave bits and pieces there for people to practice with. So that's important. Again, make sure when you draw up those 0.3 mil doses, they are checked as well by somebody else, an independent person. All right. Now at the bottom there, we've got another little label, just some information that needs to travel with the vaccine to the vaccinator when they administer it. And that's because this information does need to be recorded in CIR as the vaccination takes place. So pharmacies that I have seen are brilliant at making their own little sundry label, and they are using that and putting that sundry label with all that information in the kidney dish or on top of a paper bag where the kidney dish has been slipped inside. And that's working really well. So you don't have to use the exact dilution record up there or what's written below. Those are examples of templates that you could use, examples of the information that you do need to record, okay? Just to note, at the end of the day, you do need to reconcile the number of doses you've drawn up and the number of vaccines you've administered. And they kind of need to match, all right? It's always a big relief when they do, I can tell you. So that's really important. Keep the vial in the dispensary or in your drawing up area or just away from it so that it can't possibly find its way back into the beginning of that chain of events and be accidentally re-diluted. That's one of the reasons for numbering your vials, but put them out of sight so they can't enter that chain again. At the very end of the day, when you reconcile those doses, it's at that point you can scribble out the details and you can discard it into your bin. So we can move on. So just quickly to touch on the vaccination event, you don't need to use one of the booths, but if you need that is supplied for you. You can certainly use a space in your pharmacy if you've got a consult room. Just be aware with your consult room, it is something that the public don't necessarily always see. Do make an effort to have it look professional and sharp and clean and clear. You are representing yourself and your pharmacy and your professionalism by showing people and having people sit in that space. And you know, I've seen a little bit of both. And do encourage people to represent themselves well in that space. You'll need a laptop there to record the CIR, the process of the vaccination. Super important to have a good glance at that dose before you administer it. This is something that could have happened 3 or 4 hours ago, been checked by somebody else, not you. It's important that you take a look at it again. Make sure that the appearance is fine, there's no odd bubble that's horribly appeared, and that the dose has remained at 0.3 mils. We do that subtly, just down by our side, making sure that is there, okay? Also, just that little picture there of measuring the acromion process down to the deltoid tuberosity. Really important to make sure that we're vaccinating in the right space. I have to say pharmacists are normally very good at this. The practice is normally really great, but we've seen a lot of television pictures, sometimes from overseas, where that needle is going in very high. And that really, the reason why we don't do that, we vaccinate lower down across, measuring against the axilla, is because that's the bulkiest part of the muscle, and we're not going to risk any shoulder injuries. So that really is something to consider and is really important. And avoid touching as you vaccinate, avoid touching the critical parts, the needle or anywhere near that hub. Keep your fingers back on the syringe. We also don't want people sort of going in with their thumb already on the end of the plunger. As you hit that resistance as you go into the skin, it's kind of possible as you hit that resistance for your thumb to just start depressing the plunger. And we don't want that to happen. We want that dose to be starting to be delivered once it's deep within the muscle. So that's something to think about as well. Okay, next one. Just looking at your observation area and any adverse events. So active observation. This is not like kind of our other vaccinations where we're sort of keeping an eye on the time and we're sending people off in 5 minutes maybe for flu or a little longer for other vaccinations. This is all sitting in that wonderful thing called CIR, that computer system. And your patient or client will turn green when their 15 minutes is up. And you actually need to exit them. Notice that. So you need your eye on the computer, not selling the sunglasses in the background. Keep your eye on the computer and exit them from CIR. What you don't want is when they come back for their second dose, 6 weeks or now 3 weeks later, that they're still sitting in observation from their last event, according to the computer. All right. So it is an active process. This program, of delivering COVID vaccinations, it's under, incredible scrutiny. We need to do things right. We need people watching our clients in observation. Make sure you've got a blanket or a pillow or a little yoga mat, something just to make somebody comfortable should they fall on the floor or have an adverse event. Think about how you could just respect that privacy, and it may be something as simple as that sunglasses stand you can see there that can be wheeled across, not asking anybody to get fabulous screens or anything, just one of those stands that can just respect that privacy a little bit. Know the difference between anaphylaxis faint and panic attack. In Auckland, when pharmacies go live, they do actually have an audit. And these are questions that the auditor will ask, do you know the difference? Do you allocate roles? Do you have a huddle in the morning and say, right, this is what, if we have an anaphylaxis event, you're on ringing 111, you're drawing up the adrenaline, you're administering it. Make sure everybody knows where that anaphylaxis kit is and can get it quickly. Just little things that are really important. Simulate an event. I know sometimes those sort of things sound a bit silly, but I know that for all of us, if you kind of visualize in your setting what that could look like and how people will respond, it gives you more confidence if the event should happen. And one more slide, and then I'm done. So anaphylaxis kit, I've seen at least 35 anaphylaxis kits in Auckland lately, and mostly they're good, but sometimes there's just the odd thing missing. So let's just quickly go through that. It needs to be in its own right, a little hard-walled container. So, a Systema container from the supermarket is fine. 3 ampules of adrenaline and a dosage chart. Have that dosage chart with the kit, not on the wall in your vaccination room, and then somebody's grabbed the kit and taken it to another area and you don't have the dosage chart. Needs to be with the kit. Tuberculin 1 ml syringes, not insulin, okay? And you'd want at least 3 of those because you've got 3 ampules. Needles, a range of needles. This is an area where there is often missing things. So we need 25 millimeter and 38 millimeter needles in those different gauges written there. All right. That is because we want to get deep into that thigh muscle, and we need longer needles for people that are a little bigger. There's quite a difference between a 12-year-old little girl and Richie McCaw, maybe. Access to a phone is really important, and bag valve masks is important. And just make sure that every single staff member knows where that kit is, because if you have the need of it, you will be calling out and you won't want to be explaining where you've got it tucked away. You want to make sure that everybody knows where to get it. Okay, that's the end of my little bit. So I'm going to hand over to Sammy now, who is running a clinic already, and he's going to share some of his tips and tricks and experience in his setting. Thanks.
Hey there. Can you hear me? Good. All right. Hey, yeah. So I know there's a lot of processes that you know, that've been brought up with this, and it can be a bit daunting, but it's pretty doable. And we do quite a few number of vaccines a day. But the main thing is most pharmacies will be all set up differently. So everyone's got to find the way that's going to work for them. So you'll have a way that it will flow in the pharmacy. So in terms of the setup, you'd need to ensure that you have all the hardware and the personnel. So certainly for us, obviously you need your contract first, and once you've got your contract, then you start looking at all these things. So do you have enough computers? Do you have enough chairs? What's the setup going to be? So you need to visualize how people come in, how you conduct the service, and how they would leave. So one of the big things in pharmacy at the moment is space. So for observation, because someone's there for 15 minutes, and if you're going through a lot of people, it gets clogged up very quickly. And with COVID, we obviously need to make sure that spacing is paramount. So you need to maintain that. So you need to kind of see how many people you can do, but you can't really know until you start the service a lot of times. So you need to be able to, what I do tell people is you can start low and then scale up, because once you, if you open up your bookings for a lot of people, you can't run it safely or effectively, then it's not really great for anybody. So you don't really want to turn people down either. In terms of the things you want to look at first is, obviously, as mentioned, is make sure everyone's trained and everyone's understands the system, because unlike you know, doing other vaccinations, all the recording is done live. You can't retrospectively enter things back, so you have to make sure you have someone at each point to essentially enter data, do the vaccination, process that part. So yeah, so you're going to need personnel to check in, the vaccinating, and then obviously the observation. If you're doing small numbers, some people can do, you know, 2 roles there. Even if you're doing very small numbers, it could be just the one person doing all 3 roles with a support person there if need be, you know. But yeah, it depends how it works for your store, but always good idea to sort of visualize and then sort of you know, have a dry run and see where things where king points can be. There are certainly when we do our service, there's some tricky things that come up. Obviously, people with no NHI numbers, that takes up a bit of time to sort out if need be, and then having to ring. Who do you ring? If you have problems with CIR, for first timers, it's very, very tricky. I found it very unintuitive, but once you get the hang of it, finding things very straightforward, but the initial step. So making sure that you're understanding how to use that program, also the booking system, making sure that you have the right numbers in there, so your capacity is right. You can't open it up for 200 bookings when you can only service 50 safely for a day, say. So like I said, start low and then scale up as you can. And making sure that you know who to call if you don't don't know what to do, whether it be the clinical line at IMAC or whether it's someone at the DHB in terms of logistics and getting your opening order sorted. So those are all the considerations, I would say. But once you get into the flow of things, I just want to stress it's pretty straightforward. It's like any new service. I'm sure if anyone can look back when we first started vaccinating, it's a similar feeling. You know, it's new and you want to get it right. But once you've done one, you've done 50, you've done 2,000. So that's pretty much my experience there. And if you do have other pharmacists, colleagues who are vaccinating, hit them up, because certainly for us, even when we had onboarding pharmacies, I invited some of the other clinical lead and their pharmacists to come into my pharmacy on a Saturday to help me draw up my doses, get some experience in. So when they came to do it themselves, they weren't on their own, so to speak. So yeah, so you can reach out, and most pharmacy colleagues, they're all pretty good. So yeah, and they're more than willing to help. So yeah, that's pretty much it. But if anyone's got any specific questions, then yeah, happy to answer them too. So I'll pass that on to the next person. Yeah.
Thanks very much, Sammy. I appreciate that. So just a wee reminder, if you've got any questions, just pop them in the Q&A box at the bottom. I am conscious of time, so I will go through this very quickly. Now, why is this not? There we go. So vaccine spacings. This is literally hot off the press. It's been a topical topic today. So at the end of September, the advice for leaving a gap between community or Pfizer vaccine and other vaccines was updated by the Ministry of Health that you don't need a gap now, okay? There is an exception, that's the Zostavax or the shingles vaccine, where there is a 7-day gap before or after receiving the Pfizer vaccine as advised. Now, overseas vaccines. So we do have them, they do crop up. It does depend on what vaccine they've got and what doses they've received overseas. The Delta variant has changed the advice around that. So you can get information in the immunisation handbook. It's chapter 5 is the Covert chapter. But to be honest, just get individualised advice on the 0800 immune line. We've got the most up-to-date data on exactly like if they've had 1 dose of Janssen overseas, the advice around how many doses of Pfizer they get in New Zealand has changed. So just give us a bell. And obviously, after today's 1 p.m. announcement, the Ministry of Health are going back to suggesting a 3-week spacing between dose 1 and dose 2. So there's obviously bigger political issues there. At the end of the day, healthcare professionals, we just want to know the clinical data, and Pfizer ran their clinical trials with a 3-week gap, okay? So between dose 1 and dose 2, that is where we get that 90+% efficacy rate. So that's good, okay? It's up to the patient. If they want to increase the gap between dose 1 and dose 2, that's fine. But by going with that 3-week gap, they will be protected quicker. The protection between dose 1 and protection after 2 doses is quite a big gap. So if you're waiting around 3 weeks, not fully vaccinated, that could be a risk. So yeah, if they can come in, come on in. Just, I appreciate it's frustrating, but it's one of those things. It's a rapidly moving space, and we're doing the best we can with the information we've got. So 12 to 15-year-olds, so obviously this has been a recent change. So while children aged 12 and up can legally give their own consent, the preference is that this should be the exception and not the rule. Written consent can be required if the vaccinator's preference, but we would prefer to see a parent or a guardian there present to provide support, as co-consent is best practice. The Ministry of Health have got a bunch of documents helping guide around what that looks like. The most common side effects are very similar to what we see in 16 and over, so there's not much different in terms of advice to give to the patient. So myocarditis and pericarditis. So a little recap, myocarditis is inflammation of the heart muscle, pericarditis is inflammation of the lining around the heart. So this is a new safety signal that wasn't picked up in the clinical trials. We only found it when we started vaccinating millions of people, as it is such a rare side effect. That is the whole purpose of phase 4 clinical trials, and it is a sign of calm and international collaboration working, where we're seeing quite low numbers, but it is something that is linked with a vaccine. So myocarditis and pericarditis has been added as a side effect to the data sheet of the Pfizer vaccine. So the background rate, that's important to consider. About 100 cases a year in New Zealand, more common in young males. A variety of causes can bring on a bout of myocarditis, and symptoms are what you'd expect: chest pain, shortness of breath, racing heart, palpitations. Now, if a patient developed any of those symptoms immediately post-vaccination, you would be thinking that's more attributed to a stress or anxiety response. That's because with myocarditis, pericarditis, we tend to see in the studies that they've done, those symptoms generally, the chest pain, shortness of breath, palpitations, usually occur 1 to 5 days post-vaccination with a median about day 2. It's quite an obvious trend. So immediately after, you're thinking other things, okay? So now, if anyone experienced any of those symptoms in the 2 weeks after having their Pfizer vaccine, they should seek prompt medical attention. It generally self-resolves. There's not much treatment apart from supportive. It's just rest and being monitored. So in terms of the occurrence of this, so the risk of developing myocarditis from the vaccine is about 1 in 25,000. And that happens generally, we find, more often in young males and after their second dose. But when you're comparing that risk of myocarditis from vaccination, you can't compare it just to the background rate. You've got to compare the risk of myocarditis from vaccination to the risk of myocarditis from COVID disease. In COVID disease, you're 4 times more likely to develop myocarditis. So that is why the CDC have outlined, and they've said the benefit of vaccination does outweigh the risk. And I do want to make a suggestion that you all go and watch the webinar that 2 of our medical advisors did on this exact topic. They mention all the studies. It's really good. And they also cover the effectiveness of the vaccine considering the different variants. And that's available on our website. So who can't get the vaccine? It's really easy to remember. The only true contraindication is a history of anaphylaxis to the first dose or to a component of the vaccine. That's pretty standard with all medications. If they're going to be reacting to a component of the vaccine, it's most likely a peg allergy. This is only a rare condition, and even then would suggest you get advice from an immunologist or one of our medical advisors. Immunologists have vaccinated several of these people without issue. Like all vaccines, you would delay if the patient is acutely unwell. So cardiac conditions in themselves are not contraindications or cautions. So if they've had a previous case of myocarditis, it is resolved and it wasn't caused by the Pfizer vaccine, by all means, vaccinate them. Perfectly safe too. If they developed myocarditis from their first dose, they should be referred to IMAC, to our medical advisors, where they're looking into alternative vaccination options. In terms of a suspected allergic reaction to the first dose, if they come into you and they said, oh, I came out in a rash after my first dose, understand anaphylaxis as a sudden onset with rapid progression with involvement of multiple body systems. So you really want to dig down and gather further information. It's most likely going to look like calling the 0800 immune line or bringing in the GP so they can look at the notes and see the diagnosis from the emergency department. But we don't want to unnecessarily push people away because they developed a rash after the vaccination. That's not anaphylaxis. Please come back for your second dose and get that full protection. So if in doubt, just seek further advice, clinical advice on that one. So the cold chain. Now, COVID has shone a spotlight on the cold chain, and that goes for everyone, every provider out there. We've gone by how we've got along this far, but Pfizer, it is a bit of a finicky medicine. It does sit in the normal cold chain. It's just a 2 to 8 degrees medication that it sits there. But it's just reminded of us that there's a lot of resources on our website that you can access. There's the national standards and there's this year's addendum, which covers the COVID vaccine. We do have a specific cold chain policy, which covers just really the COVID vaccine, signing for it, how to pack for offsite, some really key details. Now, just remember the cold chain covers people, processes, and equipment. It's not just enough to have a chili bin. You need to have processes and trained staff. Otherwise, you risk the vaccine efficacy and you risk patient safety. So it is important to get it right. And it all comes back to that policy and getting people to read it and follow it. So vaccine fridges. So again, we're seeing all sorts of fun things out there. So I've spoken to colleagues and I speak from my own experiences as a locum. We've seen a wide range of fridges out there with some creative practices. So it's just some key reminders with your vaccine fridges. Really key, please don't overstock your fridge. Consider your first of the month orders, maybe split it into two. Airflow is very important to ensure consistent and stable temperature. So stock should be well spaced. You need to allow that airflow. We need to have a gap between the sides of the fridge and the back plate. There should be no medication sitting on the bottom of the fridge. It's far too cold. And this is a big one for pharmacy. Take them out of those plastic bags. They shouldn't be in there. If you have a plastic bag, it creates a much colder environment in there. You need to have your daily min max and your weekly data logger review and compare the two. That's going to be your early warning sign that something's askew if those aren't they're copying each other. Offsite. Now, this is going to be more of an issue. Up until now, the people have come to the vaccine. We're going to have to now take the vaccine out to the people, and that's fine. Before you conduct offsite vaccinations, it must be written into your cold chain policy. IMAC are more than happy to assist with this, and it's just not a matter of having all the equipment. Like I said, you need to know how long it takes to pre-cool your chili bin. You need to know that you need 2 batches of ice packs ready to go. You need to know to take spares. You need to know to monitor every half an hour. The staff need to know this. So there's a lot to cover. There is a lot of templates out there that you can just fill in your little personal details. So it doesn't have to be onerous. But just seek help. You don't have to muddle through by yourself. So I've got a couple of case studies that I'm going to gloss over, but the one I did want to cover on very quickly because I know I want to get to the Q&As. So this was a particular case study where it's a regular size pharmacy. It is a new pharmacy, new premises, low script numbers, low foot traffic. They were next door to a GP who wasn't vaccinating, but otherwise it's a fairly medium-sized pharmacy. So they actually removed about 3 gondolas and really rejigged all their shop space and shop shelving. So because they were new, they only had 1 pharmacist. And so they hired 2 vaccinators, and that pharmacist just had the role of observation. So the patient would walk in just inside the door. There's a receptionist there. The receptionist checks them into CIR, and then they have a seat. And they actually use the gondolas to split reception from observation seats. When the patient was ready to be called up, the vaccinator would come down and get them, take them to the consult room, and then return them back to observation, because otherwise they quite often went back to reception and then everyone got all confused. So a key learning that they said that they found was that they initially tried just the existing shop staff member to do normal shop staff, business as usual, collecting scripts, doing sales, and do the CIR, and they said that was just way too much. So they hired another shop person who did the CIR, and they managed to do a bit of dusting around that, but mainly dedicated to that. And that for them was their big learning initially. Now, as Sammy touched on, the changes in levels have impacted this particular pharmacy quite a bit, and they've pivoted really well. So they've basically, with the spacing, they went from about 20 seats in their pharmacy to about 3 now because of that 2-meter spacing rule, and plus allowing space for their business as usual patients. So the patients still walk in the same way, but now they've got vaccination booths in the shop floor. Okay, so they've still got, and they've taken all the stock off the shelf because now they can't access it. But now, once the so this is everyone waiting to be called into their vaccination booth. Once their vaccination is complete, they actually go out into their car to complete their 15-minute wait. And they have the CIR observation admin staff member actually waiting out in the car park. And they know they've designated part of the car park to be just the COVID patients doing their observation. They go up and they go in and check on them, and the patients are told, if you've got any concerns at all, honk your horn. As soon as they hear the honking of the horn, the admin staff and the pharmacists run out. And I think that's a really effective way to do things. And it's just interesting. Everyone's got different ways of doing it. Talk to colleagues, see what works for them, because you might pick little bits of everyone else's ideas to find what fits your pharmacy. Resources, obviously the space moved very quickly, so please have a look at our website. We've got some really good resources if you want to put them on social media for patients as well. And the clinical toolkit is a new thing we've implemented. I appreciate you all get so many emails and there's so much clinical information. So once a month we release this. It's got everything clinical that's been updated recently in one nice little document for you. Right, so I'll open it to the questions to the floor. Kate, do you want to facilitate that, if that's right?
Okay, let's have a look. So we've got a question here from Karen. I was observing at another site last weekend and one lady that didn't have photo ID, but her date of birth was inconsistent with what was given and entered on CIR system for her first dose. What would you recommend to do?
Sammy, have you had that situation?
So what was the question? They didn't have ID?
I think well, yeah, technically we're not supposed to really be asking for ID, but I think perhaps what was on the CIR was inconsistent with what she was saying, I presume.
So in a pharmacy, I guess we have the luxury of a dispensing software, so we can actually ask her for her details and see if we can find her NHI that way. If not, then and if she hasn't been engaged in health services, either a GP or hospital, we would have to create an NHI for them. But if they have recently, you could even, if you get no joy, you could actually ring the Ministry of Health hotline, and they can actually help you find an NHI. And if they don't, they can create one. You don't need an ID to be able to create an NHI number. So for the COVID purposes, you just have to ring them up. Yeah. So yeah.
Awesome. Thanks, Sammy. Yeah, it's a really tricky one and can be quite awkward when you're on the spot there. All right, so another question from Karen. The Ministry of Health helpline was closed on Saturday, so we couldn't just give her a new NHI. Probably wouldn't want to give her duplicate NHIs to start with. But I remember how much fire Ashley Bloomfield got for requesting people, when people were requesting photo ID due to the illegal refugee status of some patients wanting to be vaccinated but don't have ID. How do we confirm their date of birth if they don't have ID? And I guess that Sammy answered that.
Yeah, you just have to take the word for it. Yeah.
Yeah, you do. And this other,
Area
you know,
vaccination.
exactly. You can check their full name. You can also on CIR go into the profile and check any previous addresses to confirm that it's the right person as well.
As a last resort, I would say you get them fill out a consent form, so you have a manual copy of the vaccination, and when the centres open up, I think most of them open in the weekends now because of this, but if you get them to sign a consent form, that's going to cover you.
Lovely, thank you. All right, so anonymous attendee, I had a patient ask about the maximum time between doses. I contacted the COVID line, but no answer. Do you have any answer?
Yeah, so there is no maximum time between dose 1 and dose 2. If you want the best coverage, go for 3 weeks, go for 6 weeks. We've got really good data on that. But if that patient's they've read something on YouTube, or they're a bit hesitant, that's fine. If they take 6 months to come back, hey, they might not get the same efficacy rate as someone who did 3 weeks, but they will have definitely better protection than just 1 dose. So in short, no maximum period of time, just get them in and congratulate them. Well done, you're here, So
Okay, so another question here. Where observation was in the card, did the administrator have CPR level first aid?
yes, they did. So the other consideration is with primary care, with GPs, it's a little bit different from your DHB run clinics, where their nurses basically sit in observation, but the presumption is, similar to a GP practice, the receptionist may not be CPR trained, but the doctor is within calling distance. So the rules around that CPR requirement for observation, as long as that pharmacist or that doctor is right there ready and within calling distance of help. But I mean, to be honest, just get them all on a basic life support course. It's a good thing to have for all your staff.
Thanks, Olivia. Nancy has a question. I had a patient for dose 2, but could not find them on CIR. What is the process?
Yeah, these curly ones, to be honest, just call up our 0800 line. And there was a question about someone couldn't get through to one of the helplines. I can tell because I just did a weekend shift that IMAX open over the weekend. But in terms of that, and because I do get these, we had to go back, we had to look at the booking system. This patient was adamant they hadn't received their first dose. We went back to the national booking system and figured out, no, actually you booked your first dose and your second dose at the same time and you got your first, and then there was like, oh, yeah, because if they don't bring their card, it can be frustrating. But basically, if they turn up and they're not in the system, they're there for dose 2 and they didn't have dose 1, you've got to basically become a detective. So it means calling all the 0800 lines, call us for support, go into the booking system, see if you can talk to them. Like, do you remember doing this? And do you remember doing that? Ask them if they've got a card. You sort of have to ask around the whole thing. You've got to check in, is this patient of sound mind? Could they got confused? Is there any family members who maybe took you the first time? There's no short answer, but also calling the CIR helpline can sometimes help as well.
Awesome. There's another question here for admin staff. The My Vaccine training, immunisation support worker training, are these compulsory too? No, they're not compulsory, but they're optional and they're highly recommended. They provide some really good information about vaccination conversations with the general public in case they get some awkward questions across the desk. And also there's some good information around cold chain and observation roles in that support worker training. Yeah. I think I think that's all our questions there. A few in the chat.
Yeah, there's a few in the chat. So what is the ruling now regarding someone who's had an AstraZeneca vaccine? Sally, do you know that one? Oh, you're on mute. It depends if they've had dose 1 or dose 2. Yeah.
Yeah, it does. There's different recommendations for that, and it changes so quickly. I had a question like this last week about one of the Chinese vaccinations, and it's not enough now for us to just look back on our data that we've had sent to us. We need to be looking up that as the questions are. So what we really recommend is for any of these type of questions with regard to overseas doses is that you do call the 0800 immune line because there's so much change in that space. And then you get the right information on the day for the person in front of you.
Awesome, thank you. There's one more. Is there any extra assistance in writing up the SOPs required for the clinical assessment?
I wonder if that means for the
Sign
like the
off.
wet run audit, the
Yeah.
site readiness assessment. It could mean that. From IMAC's point of view, you know, when we go in Auckland, we're going in after they've done their SOP and they've been approved by NRHCC to go ahead. And I know that the team at Metro Pharmacy in Auckland, you know, are as busy as they are trying to offer as much support as they can, but nothing official as far as I'm aware. Again, I think somebody alluded earlier to saying that, you know, I think it was Sammy actually, you know, talk to other colleagues who've done this. You know, pharmacists tend to be a friendly bunch, supportive of each other. There's lots of people out there now who have gone through this process and know what it's like, and you know, probably would be only too willing to assist.
I wonder whether it's worth, if you're a member of the Pharmaceutical Society or if you're part of the Unichem Grand Cross or Guild, speaking to their practice pharmacists. I know that they've been working pretty hard on putting together support collateral for their members.
Yes.
Lovely, thanks. And we've got a few more questions. Can you have doses at different sites?
Yes.
Well, yes.
Yes,
One
you
arm,
can.
and then the other arm, the dose 2. Change it up.
Or is that
And also
vaccination
different
sites?
locations, yeah.
Oh, different
Two ways
sites.
you could
Yes, I was
interpret
thinking
that.
different. I thought different locations.
So does that mean we left
Pick your
the right
arm.
brain?
Yeah.
Yeah, you can get it wherever.
Truth
As
of
long
both.
as long as there's that 3-week gap between dose 1 and dose 2.
Although there is the point about being able to get the vaccination in now, I'm not the expert here, is it the thigh? If you don't have...
Yeah, so if you don't have bilateral lymph clearance, yeah. So if you do have a patient, generally they'll know who they are. They'll rock up and they'll plonk down in front of you and they'll say, I can't get vaccinated in my deltoid. You have to do me in my thigh. These are generally women who have had their lymphs removed, or there'll be some sort of medical condition. Most of the time, if someone's requesting it to be administered somewhere other than the arm, and we've taken a call about injecting the buttock, that's a big no-no. It can be administered in the thigh for medical conditions. It's got to be indicated, so please do call our 0800 line for advice, but don't be too shocked if you do occasionally get asked to administer in the thigh. That is fine and it is indicated.
So I think that's us covered all possible interpretations of site.
All right, so if somebody's having chemotherapy, are there any special practice points we should be saying?
Not really, because let's consider risk and benefit, where, okay, they might not have the best immune response if they've just come out of a chemo cycle, you know, considering like, oh, what if we space it between cycle 3 and 4 and you're trying to work it all out, but then they're a bit sick and they don't come in, versus they're really, really vulnerable. Are we better just to get dose 1 and dose 2 in them and just get them protected for what small immune response they get? So no, if they're going through chemo, you can touch base with them and validate them for being there and be like, have you spoken to your specialist? That by now we've had the rollout since February. If the specialist hasn't been in touch now with a very specific direction about when to get their vaccine, just give it.
Exactly. If someone's on a short course of prednisone or something, are we better to defer them until they're done?
No,
Go for it.
Vaccinate, that one.
And to finish on the same note, pregnancy and breastfeeding, it's now recommended?
Yes.
No risk to fetus?
No risk to fetus. Millions and millions of these doses have been given around the world, and there has been no reported risk at all for fetus or wee babies with breastfeeding mums.
We've got a couple of excellent webinars that Dr. Nikki Turner covers this and actually goes into the data around that, but there's no mechanism it could go to the baby. When you get the vaccine, baby gets the antibodies through the placenta or through the breast milk. I like to explain it, when you eat a steak, baby doesn't get steak, baby gets the iron from the steak. Your body's very good at metabolizing things and only getting the good stuff to baby.
Thanks, Olivia. I think that's all our questions.
All right, well, we'll sign off. Thank you all so much for joining us. And thank you very much for Andy joining us from the ministry, and Sammy for sharing your experiences. So thank you all for joining us. This is a recording if you think it's of use to other colleagues of yours. And of course, IMAC is here to help with any educational clinical support that we can offer you. So thanks very much. Have a lovely Wednesday evening.
And thank you to everybody for their hard work, both on screen and out there in pharmacy land.
Thanks, Andy.
Thank you.
Thanks. Bye.